Hi, this is Dr. Chen, and I'm here to talk about acute hemolytic anemia associated with acute HIV infection. Anemia is common in HIV infection as it can affect hemopoietic cells and can impair in production of any hemopoietic lineage. HIV proteins and enzymes are also implicated in the growth of hematopoietic stem cells in the bone. However, the incidence has reduced after the introduction of antiretroviral therapy. Other common causes are anemia of chronic disease due to HIV or opportunistic infections. Iatrogenic anemia from myelosuppressive medications is also a likely cause. Deficiencies of vitamin B12, folate, and iron are also frequently reported in these patients. Low EPO levels have been reported repeatedly, and it's possible that a blunted response to EPO might be responsible. Here we present a case where autoimmune hemolytic anemia was the cause of acute anemia. A 20-year-old male presented with exertional, non-traumatic bilateral lower extremity pain for 3 days with limited weight bearing. On presentation, the patient had an elevated temperature of 100.6, a heart rate of 120, and a BP of 109/69. On examination, there was exquisite tenderness over bilateral calves and hamstring. The patient reported being sexually active in the past with unprotected sexual activity with multiple partners of both gender. Initial laboratory workup, hemoglobin of 8.9, MD of 9.3, WBC of 10,000, CRP of 12.7, ESR of 52, CPK of 413, and B-dimer of 11.41. Hemolytic workup, chapter 174, reticulocyte count 5.27%, and LDH of 338. A CT scan of the lower extremity shows soft tissue edema, and a CT scan of the abdomen did not reveal hepatosplenomegaly. During the patient's stay, he was noted to have a progressive decline in heme to 6.8 and required 2 units of PEC transfusion with further improvement. A screening 4th-generation HIV test returned positive. A PCR test showed 200,000 copies, and the C count was 366. The patient had improving in his lower extremities, and the EMG showed normal indices and normal velocities. He initiated antiviral therapy, improvement in incidence and ability to walk. Several mechanisms involved in the development of hemolytic anemia in patients with HIV. Antibody-mediated hemolysis, hypergammaglobulinemia, and immune complex formation leading to microangiopathic hemolytic anemia are common mechanisms. Management of anemia in patients with AIDS involves correction of underlying reversible causes like discontinuation of offending medications. Antiretroviral therapies reduce both the incidence and the degree of anemia in all groups of HIV infections. Corticosteroids, IVIG, and splenectomy are the mainstays of therapy. During significant hemolysis, corticosteroids are administered as first-line therapy. Most patients respond with an increase in hemoglobin within the first week of administration. IVIG with steroids should be considered for cases of severe autoimmune hemolytic anemia when a rapid response is needed. Splenectomy removes the major site of erythrocyte destruction. After splenectomy, a higher number of erythrocyte-directed autoantibodies are required to produce the same degree of anemia and RBC destruction. Splenectomy is indicated in patients where steroids cannot be tapered off. An appropriate pneumococcal vaccine should be administered prior to splenectomy. Transfusion-related complications could occur, including massive intravascular hemolysis leading to hemoglobinuria, tachycardia, vomiting, fever, back pain, hypotension, shock, and renal failure.